Hello everybody. So today we will be discussing about one of the most interesting and common topic in spine surgery, which is thoracolumbar fractures. It is common not only for your exams but also in your clinical practice, wherein you will be dealing with a lot of thoracolumbar fractures as an orthopedic surgeon, as also an emergency consultant. So what are thoracolumbar fractures? So thoracolumbar fractures, as the name indicates, these are the fractures which involves the thoracic and the lumbar spine. It is quite common in men between 20 to 40 years. You have to know this. It is very common 20 to 40 years, and the most common cause is high energy blunt trauma, which is RTAs. And neurological injuries is seen in about 20 to 36% at the TL junction. And usually these patients are associated with head injuries, chest injuries, rib fractures, and sometimes great vessel injuries, as well as abdominal injuries. Missed injuries are about 20% in these patients, especially when there are some distracting injuries like long bone fractures or head injuries. So why these fractures are common in the thoracolumbar junction? The thoracolumbar junction is technically defined as the area between T11 to L1. Why it is very common? Because the thoracic spine is usually rigid because of the presence of a rib cage and the coronal orientation of the facet joints. We discussed about the orientation of facet joints in the anatomy of spine module. The coronal orientation will be seen in thoracic spine, and the spinal canal is relatively narrow in the thoracic spine. Whereas in the lumbar spine, it is very flexible because of the large discs, sagittal orientation of the facet joint, and there are no ribs. And the spinal canal is relatively larger in lumbar spine region than in the thoracic spine. The other difference is it is the presence of cord in the thoracic region, whereas it is the presence of dura and nerve roots in the lumbar spine. The thoracolumbar region, which is mainly T11, L1, but it can extend from T10 to L2. It is a transitional zone between the rigid thoracic and a flexible lumbar spine. And there is significant amount of biomechanical stress which is happening at this junction, and that is why thoracolumbar fractures are very common between T10 to L2, or especially between T11 and L1. When a patient comes to the emergency room, what are you supposed to do? First and foremost, whenever you are suspecting a spine injury, you have to immobilize the patient. And even when you are transporting the patient from the trolley to the bed or from the stretcher to the bed, you are not supposed to lift the patient just like that. You have to use something called as the spine board, which is usually available in almost all the tertiary care institutes. So you can see the spine board here, and you have to call the attendants, or if the patient is conscious with GCS 15, you have to ask a proper history about the mechanism of injury, what happened, whether they were traveling in a two-wheeler or four-wheeler, whether there was a flexion distraction type of injury or a seatbelt type of injury, or what is the type of injury. The next most important thing is rule out head injury and any other injuries in the body. Whenever you are ruling out injuries, you have to use log roll maneuver. This picture is from the Atlas of Emergency Procedure to show how log rolling is being done. Log rolling should be done with minimum of 3 to 4 people, and you have to place your hands in respective position, and as a team you have to rotate the patient. You should not turn the patient like this and that like you want or need, because spine injuries, especially in patients with normal neurology in a suspected spine fracture, you have to be extremely careful not to destabilize the spine, because it can cause or result in neurological injuries. So neurological examination is mandatory, and we have discussed in detail about what are the muscles and sensory dermatomes and myotomes in the examination section. Perectal examination is very vital and mandatory in all the patients with thoracolumbar fractures. So what all will you look at it in PR examination? The first and foremost thing is the bulbocavernous reflex. I'll be discussing about the significance in the next slide. The next thing is the perianal sensation, which is usually supplied by S3, S4 and S5 in concentric circles. So that is very important around the anus. Then you have to look for voluntary anal contraction. Insert your little finger inside the patient's anus. Ask the patient to increase the intra-abdominal pressure, just like ask them to strain or ask them to cough. When the patient increases the intra-abdominal pressure, there will be voluntary anal contraction. If it is present, it means that is intact. At the same time, you have to look for the anal tone. So in a normal patient with intact anal contraction and anal tone, when the patient is straining, you will not be able to take off your little finger from the anus. That is the normal anal tone. The next thing is the anal wink. Anal wink is an involuntary anal contraction. You can use the blunt tip of your knee hammer and you can just poke around the anus. There will be contraction of the anal sphincter. That is anal wink. So these 5 things are very, very important, especially in a patient with thoracolumbar fracture. Now coming to bulbocavernous reflex. We have discussed this in detail in the neurological examination module as well, but again I am insisting the point. This is one of the most important reflex. It is a spinal reflex.